So you wind up in an intensive care unit and there are doctors you've never met in the hospital taking care of you. What happens in an ICU? Tonight, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. And with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, American Academy of Family Physicians Foundation, and South Dakota Academy of Family Physicians. Avera Heart Hospital, Dakota Allergy and Asthma, CoBank, Fishback Financial Corporation, Vance Thompson Vision, Brown Clinic.
Good evening. Good evening and welcome to On Call with the Prairie Doc. Finding yourself with a condition severe enough to land you in a hospital or an ICU can be an unsettling and distressing event. Then, at a time when you might like to have your family doctor or your primary care provider, you meet someone called a hospitalist. There are a lot of questions that arise in this situation, but first let's take a look at this week's Prairie Doc quiz question. First, find the best answer. What is the biggest challenge for hospital systems regarding hospitalists? Number 1, burnout. Number 2, payment. Number 3, keeping focus on practice mission. Number 4, retention, or keeping them as employees. Tell us the best answer. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays originally written for this show comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your questions about the ICU or the hospital or the ER or outpatient care as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Dr. Mike Heisler with the Sioux Falls Veterans Administration Medical Center and Dr. Jennifer McKay, who is a hospitalist with Avera Health. Thank you both for joining us.
You're welcome.
So, I mean, we can talk about a lot of things, and we're inviting an audience to kind of frame this discussion, but you are an intensivist, and you are a hospitalist. And I've been all of those, plus an outpatient doctor, plus an ER doctor in my time, because I'm an old guy. So this is a new system. There's changes that's happened. Mike, tell us about the changes that happened. I mean, 30 years ago, what was it and what has evolved and why?
Well, you've done it. I mean, you're of that group of physicians that did it all. And then people began to realize that, first of all, the science was expanding just way too rapidly to stay on top of it all. Secondly, physicians began to actually want to see their family and go home periodically. And then thirdly, then hospital administrators began to say, we need to be efficient with how we use resources in the hospital, and we want to improve outcome and care. So those forces came together, and people said, what can we do to change the system? And that's when people who really focus on inpatient medicine, hospitalists and intensivists, began to appear on the scene.
Right.
And for families it matters, because they used to see their own person in all those settings, and now they end up at the hospital you're not there anymore. Of course, you are there because of who you are, but they bump into a person like Jen, or they bump into a person like me who they've never met before, and they bump into us, and in 20 minutes we have to talk to them about major, major tough issues. It's not easy.
Yeah. And my whole life changed when the ER doctors came, and I didn't have to do ER anymore. Oh my gosh, that was a change. So, as a hospital, you know, you're a young hospitalist, Jen. What made you decide to go into this field?
I love everything about the hospital. I like the ebb and flow, I like the unpredictability, I like the patience, I like the thinking, and I think the other piece is just this kind of gap that I noted was occurring, and I didn't feel comfortable leaving my really sick people in the hospital. So I learned very quickly, and what's really fun is my daughter's going to be 14 next week. She was 4 months old when we founded our hospital medicine program at Avera. And so I have to credit both my daughter and my mother-in-law for helping us establish that and help our patients in Sioux Falls. So I honest to God, I think it was just born out of a love for what happens in the hospital and the kinds of things you encounter.
You know, you said it earlier when we were talking to our pre-professional students about the value of the hospitalist being I mean, it's a quiz that we get every new patient. It's a challenge. It's what is the problem? How can I help them the best? What is you know, it's just this puzzle every day, all day long, working out puzzles. And in the ICU, would you think it's easier, a hospitalist has this broad scope, you have to know everything about everything. The intensivist, pretty much the intensivist is pretty standard. Is it a little easier, do you think, a little more focused?
Well, I've mentioned to you before, I think the toughest role in medicine are the family physicians who have to know everything. And in the same day can see someone in the ICU and 2 hours later someone in the pediatric ward. Intensivists do have a little bit more of a defined boundaries around what they need to know, but that whole area of medicine, like hospital medicine, just expands year by year by year. A number of entries in, you know, referee journals and published articles increases by 600,000 a year.
Yeah.
So there are some limits around what happens in the ICU, but it's still really, really complex. But you could say, why does someone choose to be an intensivist? Same thing. You know, you really like to take care of sick people and help get them better. Here's a story that I think I might have talked to you about before, but people say, you know, you go to the ICU, you take care of old people. Same thing with hospitals. A lot of old people.
A lot of old people.
Well, first of all,
sick most of the time.
First of all, I really like taking care of older people. But here's the story. So, 42-year-old fella, absolutely healthy.
Not that old.
Not old at all. Absolutely healthy. 2 11-year-old sons, twin boys. He ends up fracturing his hand playing baseball. He ends up with a navicular fracture or whatever. Actually, more serious fracture. Ends up in a cast. Goes to follow up. No one checks the cast. Comes to the emergency room and now is really sick. Elevated white count, fever, not feeling well, etc. They still don't check the cast. He ends up in the intensive care unit, absolutely flat out septic and septic shock.
Septic meaning?
Meaning that you have an infection somewhere in your body that then spreads into your bloodstream and then begins to affect how other organs function.
Well, it's going to kill you.
It'll kill you if you...
Sepsis kills.
Yeah, I mean, sepsis is the largest, you know, the leading cause of admissions to intensive care units in the United States by far. Anyway, here's the short story. So people say, why do you like intensive care medicine? Because if you do intensive care medicine right, that 42-year-old dad gets to go home and be a dad to those 11-year-old boys for another 20 or 30 years. If you don't do it right, that's not how it works out. And I think that's true for hospital medicine too. You get really sick people where you're asked to use all your skills.
One of the things I've learned, especially taking care of older people, is you have to, I call myself a hospital doctor because so many of my patients think they're going to go on hospice.
Oh, it's
so I'm like, I'm your hospital doctor. I'm here to be Dr. Holm for you while you're here in the hospital. And then sometimes I include things like, I'm much better looking.
Yeah, indeed you are.
But at the same time, you're totally right. And I think the other piece that I think is really satisfying, but it's also a ministry and a mission for me, is the idea of talking about the hard stuff when you get in the hospital. A lot of people come in, they're facing dire circumstances, they have not talked to their families about it. And so it's up to us a lot of times to start facilitating those conversations because it can be very, very difficult.
And here's another thing about it.
But before you go any further, So tell me what was underneath that guy's cast.
Oh, he had a major infection that had gotten down into the bone and spread. He had an abscess in his wrist that had begun to track up in his soft tissue.
But he should have, yeah,
They should have taken the cast off a week before
Yeah.
in the emergency room.
yes, when he was there.
So,
Our life is filled with these shouldas, though, aren't they?
oh yeah, they are. And you can't blame anybody. I'm just saying that once you know what the problem is, you get to try to fix it.
Yeah.
How much fun is that?
Fixing it, and then they go home.
And then they get to go home.
Oh, I love
So,
that.
Yeah, yeah.
So you were going to say another story.
No, I'm just saying that in a hospital, it turns out if the systems work right, we don't work in silos. Good programs, the intensive care folks and the hospital medicine folks work hand in hand. For example, here's a number that's kind of interesting. So there are 6,500 ICUs in the United States. There are 4 to 6 million admissions to the ICU every year in this country. The idea that there ought to be an intensive care specialist in each of those ideas might make sense, but the reality is there just aren't enough. So who takes care of 80% of the patients that are admitted to intensive care units in this country? Hospitalists.
Yeah.
Yeah. And for us to do well, for us to be useful to the patients that we're lucky enough to get to take care of, we really need to talk to each other.
Well, I think we're more
Yeah.
experts in the system, right? I always think
Yeah.
of myself a little bit like I could pretty please my way through any day at the hospital I work because I know everybody and I know all the ins and outs. But that's really the trick is
The pretty please.
you have to know the medicine, but you also have to know the system. And so when you talk about going into a hospital, sometimes we would say, you need to have an advocate with you in the hospital. Well, your hospitalist or your intensivist is that advocate from a physician standpoint and can really help coordinate all the care that happens because it's so complicated.
So you just said something that was very important, and I don't think people will recognize that. There is this aspect of knowing everything there is about that particular illness, and to know to start the medications, and to know to get the right care provided and call that specialist, whatever it might be. But it's also in knowing how to say pretty please and let's get this done.
Mm-hmm.
I remember a guy came into the emergency room. I brought him in, my neighbor, and as I'm rolling him into the room, I said, I want a gram of Rocephin, and I want blood cultures, and the cultures need to be done right now, and the Rocephin needs to follow it, and it needs to be done within the next 3 minutes, and I need it right now, no delay. And I knew who to call on, and the nurse who knew me and was my great friend got it done. Otherwise, sometimes there's these delays that happen because you just didn't have the right.
Well, and I think in South Dakota in particular, where we have a lot of rural facilities, we're lucky at Avera to have our e-care hub because a lot of the patients I get have already been managed in a clinic. They've already been managed in an emergency department, and now they've failed all of those treatment options, and it's just progressed to the point they need specialty care. So that's where you start looking at things like technology to try to make you more efficient and really use that system stuff. It really, I think it helps you work better as a team.
But the pretty please stuff is really kind of fun.
It is.
Because getting it done, I mean, having the right, how to grease the skids and.
So here's a number. If you end up in the hospital with sepsis, I keep talking about sepsis because it's such an overwhelming issue.
Yes.
And you don't get the right antibiotics within 1 hour, this is what the point you were making,
Right.
within 1 hour, for that reason alone, for every hour after the first hour that you don't get antibiotics, your chance of not surviving that hospitalization goes up by 7%. So you could say to all the people who are listening to us tonight, but I want my own doctor taking care of me.
Yes.
Well, that may be true, but your own doctor, first of all, doesn't know this area maybe as well as Jen may or I may. And here's the other thing that people forget. When you come to a hospital with an intensivist or a hospitalist, we're there 24/7. So we don't have to be there in the morning and then go do everything else while you wait and then get back in the evening. I know what's happening at 7 o'clock, or we've worked together, so that's why I keep saying we. And if we get at 8 o'clock, if it hasn't happened, we know it hasn't happened, and we fix it by 8:15, not by 5 o'clock tonight. If it's my family member, I want somebody there fixing it right now.
And all day long.
Absolutely.
From Pat on Facebook, do hospitalists talk to each other when they change shifts like nurses do?
Ideally, we do. It's very challenging to convey all of the information about a patient in every single handoff. We have a couple things that we do. One is we have pretty verbose, detailed notes to each other. And then the other is that we leave a sign out or a handoff. We're lucky enough to be able to provide some good continuity, and even within our schedule, we have some rules kind of set up saying, you know, we want you to be on service for at least 5 to 7 days because it's going to be better for the patients. Right. But it is a good point. It's one of the biggest difficulties in hospital medicine is the handoff. Mm-hmm.
There it is. Hospital protocol, technology, and staffing change. It's hard for your primary care person to keep up with everything. Enter the hospitalist.
Hospital medicine is relatively new. Its field is only 21 years old. And understandably, individuals are still curious, what is a hospitalist? We're your primary care provider, but it's in the hospital setting. That's the best way to describe what we do. We coordinate everything. We deal with every organ. We talk with the surgeons. We talk with the subspecialists. And we're the leader of the team in the hospital setting. Medicine is a team-based sport. We're all involved. It's crucial that everyone focuses on the area that they do best. Hospitalists are specifically trained to manage acutely ill medical patients. We're readily available in the hospital, so if there's a code blue, we can be there within the next few minutes. That's hard for a primary care provider to do when they're in the clinic seeing patients. We can also readily be there at the bedside when a family member shows up and has a question right then and there, because I'm in that hospital. That doesn't mean it's necessarily better care than what the primary care provider provides. It allows us to work together as a team, ultimately giving patients the care at the right time and in the right place, and allows us both to focus on the areas that we do best. We manage medical conditions for the acutely ill. We don't do surgery. We don't deliver babies, and specifically for my role, I only see adults, so anyone 18 and above. I liken to we're the quarterback of the team. Doesn't mean we're more important, but we coordinate the care for the patient, and that may mean we're the only physician involved, or more often we have multiple physicians involved, specialists and subspecialists. We help drive that care and provide that communication and tie it all together for the patient. Communication is key. That's in every field. And that's where things break down, similar to every field out there. It's communication on the front end. When they're admitted, the primary care provider knows that patient best. Not every patient who has heart failure is the same as every patient who has heart failure. So what are the specific attributes of their disease? And how do we individualize the care for them based on what their primary care provider knows? Crucial aspects of what we do are communicating with your primary care provider too. They're the most important determinant of your health, is your primary care provider. So it's crucial that we keep in communication with them both when you're admitted and discharged.
This is your program. Your questions are key to the direction of our discussion. Please call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. It's your show. We love to respond to your questions. So we had a question. Are you related to Mike McKay?
I love South Dakota because it's all like,
everybody knows somebody.
everybody knows somebody, so no, I'm not.
No, you're not related.
No.
So, but you are related to Ann McKay, my dear friend from college, who is a buddy of Jim Abbott's. That whole story, you know, Abbott, who is the president of the USD, and there's a great story there. And I don't want to tell you to get into it, but there was a lot of fun there. Related to you. But you do have a twin, don't you?
I do.
Tell me about your sister.
So we, I have a twin sister who's a OB-GYN, and she's also at Avera. We grew up west of the river, so here I am making your making your table just a little bit better because a West River girl.
West River girl.
so we grew up in Belfouche, South Dakota, graduated from Belfouche High School, went to University of South Dakota, and then trained and came back here. I married a South Dakota boy as well, and so it's home. We love it here. Yeah.
Yeah. So she loves OBGYN. I know she loves it. I mean, I've interacted with her at great end. And you love internal medicine and hospital medicine. Isn't that interesting?
Yeah, it is interesting. And what's really funny is when we went to medical school, I really did not like gross anatomy, like at all.
Yeah.
And she loved it. For whatever reason,
Why
she
is that
can
anyway?
three-dimensionally. And so I would kind of like sometimes not go to my lab class, and it would stress her out. And then she would take me into the lab before a test and teach me everything. And I'd do really good on the test.
How's all that?
You could have just had her go to class for you.
No,
Yeah.
she's not that. No, she would
wouldn't
she
have
would not have done that.
No,
She
no.
wouldn't have done that. But
Love that.
she was a great teacher, though.
Yeah, so I love, we can talk about twins and so on and so forth, but I think we'll talk about medicine. I love the idea that we just heard the importance of the handoff, and you alluded to that when a hospitalist turns over the case to the next hospitalist. But the turnover, the handoff from the hospitalist or the intensivist back to the primary care outpatient doctor. What do you think about that, Mike? Do we fall down in that
Oh,
regard?
of course we do. And if you're ever in primary care, you're frustrated endlessly. Even when people try their best, it sometimes just falls through the cracks. I think that's more of an issue with hospital medicine than it is with intensive care.
I'd say.
Don't you think?
Yeah, I'd say.
Because they leave the unit and go to the floor, and then people like Jen take care of them.
Yeah.
I think one of the biggest struggles is after they've come into the hospital, after they've been in the ICU, their medication, what were they on to begin with? And so kind of understanding the medication list before and after, that's probably our biggest risk at the time of discharge. We put a lot of effort into medications and all that, and I think that's probably the most frustrating thing for primary care docs.
You know, I had a student, a pharmacy student, hang with me for 6 weeks, and she did a study. And here I am. I think I'm the most meticulous, careful guy there is. And what she did was she asked, what did the doctor and the record show the patient was taking? What did the pharmacy show that the patient was taking? And what did the patient think that he or she was taking? And it was
0% right, I bet.
it wasn't good.
Yeah, and so you know what? So this gets back to the issue of advocate. Someone who
Yes.
can really act on your behalf because you're really sick or you're on medications, you're getting ready to go home and you're still a little bit, someone needs to sit down and say, all right, let's get this really sorted out.
Well, I think, not to mention that you're sick, right?
Yeah.
And so we sit and we try to give patients these really complicating instructions and get them home safely, but at the same time, they've just been sick. I don't know about you, but when I'm sick, I don't want to do anything, let alone listen to my new medications and figure out how I'm going to get through get to my primary care doctor next week.
Yeah, absolutely. And here's another place where talking to each other really matters. For hospital medicine and intensivists to really talk to each other and not get into silos where we live in our own worlds and never communicate. It really works when we talk to each other. It doesn't work when we don't. You know, it's interesting. If you look at outcomes from the intensive care unit, you say, what's the #1 predictor for how people do in the ICU?
Yeah.
The #1 predictor is if we're doing good evidence-based medicine. Guess what the #2 predictor is? And this study's been looked at over and over. If we talk to each other.
Yeah.
Isn't that amazing? And not just physicians, but if we talk to our nursing colleagues and the respiratory therapy and the pharmacist, and that's why at Avera, I know we did, and at the VA, you know, we have multidisciplinary rounds where we all spend each morning on rounds, guess what? Talking to each other.
You know, I was just in Wessington Springs last week, and they do that every morning at the hospital. Multidisciplinary, the whole staff sits down. It was just fabulous, and I sat there and I just really took it in because it was really one of the most satisfying parts of being in the hospital for me is that relationship between your colleagues.
We do it at the VA too, every morning, same thing. The whole team is
The whole
together.
team.
Yeah, nutrition, pharmacist, respiratory therapy, everybody's in the same room. And we're saying, where are we heading, what's the plan for today? People get better and they go home sooner when you do that.
Right.
So,
We sure did that when I was teaching. And you know, For the years that I was practicing, we would have 2 1-hour conferences together every week. 1-hour conferences, 2 1-hour conferences every week. And that collaborative discussion, I had a case like that. We have a case right upstairs right now. It's doing, this is what's happening. Those kinds of discussions are golden in keeping you up on the
Yeah, and here's another take home for people who are watching. A lot of places, like the VA and certainly at Avera, the family members, at least in the ICU, are now included in those discussions at the bedside.
Yeah.
So they're there when people are talking about where are we, what's the latest, where are we heading, what's the plan for today. They don't have to get it later from someone who might or might not have been in the room.
Right. Let me throw the criticisms that I hear. I wanted to say one, and that is that the family doc or the primary care doctor, outpatient doctor, doesn't always call the emergency room and say, I've got a case, these are what I'm thinking. Oftentimes the ER doc has to pick it up. So it goes both ways.
Yeah, that's really true.
It really does. No, you come to the situation of this kind of communication, and it's so important. But the biggest criticism I hear is family doesn't get a chance to talk to the doctor or the hospitalist enough.
Or how about this one? They talk to one physician at 8 o'clock and he or she tells them one thing. 1 hour later they talk to a different physician who's a subspecialist who tells them something completely different.
The subspecialist is coming by.
And then an hour later the hospitalist, if they don't talk to each other, is in the room and they're telling the family something. What do you think the reaction is? First of all, trust goes out the door and they begin to get a little fearful that no one's running the ship here.
Right.
And hospital medicine can really, really help with that a lot.
Yeah, I cannot say enough the value of having time with the family. And what you've said earlier, Mike, and that is to encourage at least one person to be the patient's advocate. It might be the family, but at least one person who is there to talk to the person making rounds at 8 in the morning. When am I going to see you tomorrow? Or when should I be able to talk with the physician or the care provider? I mean, the nurses do the best they can, but they oftentimes can say, well, I wish you could talk to the doctor.
Well, and quite frankly, that's the nice thing about hospital medicine. My clinic is in the hospital, so if a family member comes later in the day, I think you said it before, but they just call me and I go back and talk to them. And I think that's one of the beautiful things about it. When I had a clinic, it was sort of like one and done. You had a full clinic of patients. It was very challenging to come back and forth. I think though we have a long way to go. I think there's some thought that technology can help us, but you talked about the expansion of medical evidence. The expansion of patient-centered data is incredible. And I'm not sure how we're going to manage that, because with these electronic health records, there's just so much data that you sometimes lose the story of the patient. And we got to be careful about that too.
We could sure do a lot better by simplifying the medical records so that we would actually read it and that it would actually have the patient's story. I'm kind of critical, but that's okay. I want to talk about burnout. I want, but we'll do that a little bit later. A woman from Sioux Falls. Now I lost where did it go? How do the doctors connect with a patient and the family members so that they feel comfortable in medical situations?
So that the physicians feel comfortable or the family members feel comfortable?
The family members.
Oh, that's a good question, especially in the intensive care unit.
Yeah, and what is your answer?
Well, talk about walking into an environment that is just frightening right as you come through the door. First of all, someone's really, really sick. And second of all, if they're in the intensive care unit, then there is the possibility they may not survive. So right out of the gate, you have a whole different situation. And now you have blinkers and buzzers and alarms and ventilators and all the rest of it. It's a really scary place.
And they might die. I mean, they're so sick. That's why they're in the ICU. They're really sick.
And that's why in the intensive care unit, nurses matter so much. If you really look at outcome from the intensive care unit, we all think that we're the ones that make the difference. We're not the ones that make the difference.
It's the nurses.
It's the nurses that make the difference. That's really true. If you ask patients what they remember from the ICU, they don't remember who I am, but they remember who Sam is, or they know who Carly is. They know who the nurses are. And the other thing about ICU nurses they're just so much fun to work with. Because they take command of their patients. And
Sometimes they take command of the doctors too.
Oh, they do?
They do, but I like that.
Oh,
you know,
for sure.
it's true at
Absolutely.
Avera. It's true at the VA. We have wonderful nurses at the VA who aren't afraid of anything. I mean, that's true at Avera too. The critical care nurses are a special breed, but they're the ones, to answer your question, who know the families the most and talk to them the most and help them the most find out A, what's going on, and second of all, to be in this crazy place.
Right. No,
So-
as a physician, all the years that I did all of what I did it because the nurses allowed me to, and they red flagged. When there was a problem, they would call me. I would always answer happily, because I knew from who buttered my bread. You know what I mean?
Absolutely.
And took care of the
Well, buttered
patients.
the bread and saved your bacon.
And there's a better
know.
way of putting
But they
it.
also find out the stuff that you don't necessarily, the stuff that happens in those little passing conversations, things that have high impact on whether or not a patient's going to be readmitted later on. Or,
That's really
so
true.
I mean, I think for me, my nurses that I work with, I don't know what I would do when it comes to understanding how I successfully get a patient home, because they found out all the good stuff.
Absolutely, and a smart physician understands the importance of saying to your nurse colleagues, "What do you think?" And then shuts up and listens.
Yeah, and
Yeah.
gets what the.
What do you really think
What
is
do you
happening
think?
here?
Yeah. Tell me what you think.
Yeah.
Sometimes, if you're in a condition where you need to have the benefits of an ICU, but cannot travel or time is of the essence, then an EICU may be life-saving.
The EICU is actually a technology that was discovered by some people at Johns Hopkins University originally that allows us to be present from a remote site in an intensive care unit. The only difference between Johns Hopkins and South Dakota, from my perspective at that time, was the length of the wire. That we needed longer wires to go to Aberdeen or Bowdle or wherever. The critical aspect is that people are often teetering on their last hours of life. And so every decision that's made is critical. And for those that do that all day, every day, as part of their routine, the intensivists, they're able to come to conclusions more quickly, with more confidence, and frankly, that's their special interest. The reality is this is like air traffic control. We actually have data feeds of every bit of information that you would see at the bedside if you were in the intensive care unit, as well as their pharmacy information, their history, medical records, all those types of things are available locally. Us physicians described it as actually taking care of a patient with your hands in your pockets, because you couldn't touch them from miles away, but you had everything else available to you. 1 year in, they were in the ICU half the amount of time. The time on the ventilator was decreased by 30 or 40% for those that required a ventilator, and the death rate was less than half of what was projected. So IBM did an international study about 5 years ago on telemedicine, and came back and said that Avera Hospital in Sioux Falls, South Dakota has the most robust telemedicine in the world. We can't say that about too many things, and I'm proud to have been a part of it. I'm really proud of the amazing people we've had that have put the pieces together to make it work, because not everybody is a pioneer, and some felt like we were going down a dark trail perhaps at times, but I think it's proven itself very well.
So I've got a bunch of questions, but I thought that was so interesting to hear about the EICU and how it was developed. And then there's the emergency room and the nursing home and all of the new developments where specialists can be available to us out here in the rural area. I know that when we got an EICU, and you were part of it because you and I cared for a patient right there together, it allowed the patient to stay in Brookings instead of having to ship him down to Sioux Falls?
You know, actually, I want to say it's been about 10 years ago now. We had a terrible snowstorm over Christmas, and it shut the interstates down border to border, east, west, north, south. And in the EICU is what I really think had a good impact on our patients. And I remember after they opened up the roads, just patients just coming in, rolling in. They were really, really sick. But
too.
I think we were on together in the ICU.
And there were people down south in part of South Dakota who would never have stayed in the places they stayed, but they couldn't ship them. And so there were nurses taking care of people on ventilators with, you know, pressors to keep their blood pressure up. And the EICU, I really think this is true, save those, save those folks.
Oh, and because we were keeping sicker people in Brookings, our nurses kept up. And so we got better at it. And we all got better at, you know, this whole intensive care stuff that was important. And sometimes you don't ship people, you just take care of them.
Well, and I think the other thing is it's very hard on families to have to travel to the bigger city. That hour drive just wears people out. And I'm known for telling families, listen, I want you to go take care of yourself.
Yep.
We've got things under control here in the hospital. Go home, get some rest. So that telemedicine stuff has been a really big part of
really. And, you know, people were afraid that if they did telemedicine, meaning that there's a camera that's in the room watching the patient, that the patient and the families wouldn't like it. That didn't turn out to be true. No. The nurses sometimes didn't like it, because ICU nurses are territorial. I don't mean that critically. And they didn't want someone watching over what they were doing initially until we became a team, and then that went away. But when they did survey after survey after survey, and I'm sure it's still true at Avera, and they asked patients, and more importantly, they asked families, do you like this telemedicine thing? Every year, 95, 96, 98% said absolutely. First of all, we get to keep our folks home. And second of all, we feel like they're safe. Who wouldn't like that?
Well, and then you have that, and the doctors like it, because I had your eyes on this patient as I'm watching over him, but you know, I needed the extra eyes.
Well, here's the other thing, and we did this together. At 6 o'clock on Saturday night, we can talk over the camera, and you can say, here's what I think's happening tonight, and I'll say, that's good, Rick, go home. You know, I'll talk to you in the morning. I'll call you, and I actually said this to you. I'll call you if there's anything really serious that happens tonight. Otherwise, don't worry about it. I'll take care of it tonight. And you check out and go home. Well, that keeps people in rural communities. You know, that keeps physicians and
have a
PAs.
family.
And,
I'll have that glass of wine.
It keeps you in your own community.
You know what I mean?
And that's really, really important. The Avera e-care system is really wonderful.
Isn't that internationally pretty renowned? Or
it really is. And Dave Kapaska really does deserve a lot of credit for seeing that opportunity and making that happen.
And Ed Zawada was part of that too.
Ed Zawada's a whole nother story.
Yeah.
We all know Ed. But he's a wonderful guy and an amazing physician. And he and Dave really together led that whole thing. And it's a big deal.
We have a question about EICU for peds. Is there such a thing?
EICU for peds or ICU?
Well, or ICU. No, I'm sorry, ICU.
We do have ICU for pediatrics. We have ICU intensivists, and we have pediatric hospitalists. A lot of specialties have actually gone into that IST type mode. We even have surgical hospitalists who just take care of patients in the hospital.
So it has expanded, hasn't it? It really
has. So if you go to Sanford Children's Hospital, there are people who are subspecialty trained in pediatric intensive care who will take care of your little one at Sanford. And they're specially trained. They finish their residency, and then they do 2 more years of critical care medicine, and they get certified.
So pediatric ICU.
Yeah.
A man from Alcester asked, are all hospitalists MDs?
Well, MDs are DOs mostly.
Are there some PAs that are working part-time or part of their, or how does that work?
In our rural communities, we actually have a number of nurse practitioners and PAs who work in the hospital, do a lot of hospital work. Sometimes family medicine doctors do hospital medicine, depending on where you are. But for the most part, it's physicians,
I wanted to say, you know, I was a governor for the American College of Physicians, which is the internal medicine kind of the father.
I didn't know that. You were the governor for the state of South Dakota? I don't mean the governor, but I mean the governor for the chapter.
The ACP,
Oh, really? Nice.
And so, as the governor, this is a discussion that we were talking about. What do we call ourselves? What is an internist? People don't know what an internist is. And I always said, well, that's the surname. I mean, that's Holm. You know, Rick is I'm a geriatrician, I'm a endocrinologist, I'm a cardiologist, but my my last name is internal medicine. And that's what happens. You're an internist, but we kind of forget that.
So what ACP wants us to say is we're the physicians that are focused on medicine for adults.
Yes. And
Which is pretty much true.
good.
Yeah.
Yeah.
I mean, we move over into adolescent medicine sometimes a little bit, and pediatrics moves up, and then there's a group that focus only on adolescents. So there's that. But mostly it's adult medicine that we do.
I've said to people, okay, I'm a family physician, but I don't do peds or OB. Or I'm a pediatrician, but for old people. You know, I don't do surgery. Right. Well, but I do colonoscopies, a lot of skin surgery, and so anyway, it's kind of hard. Internal medicine, both of you are internists. We've got 3 internists here. I thought that was kind of fun. A Sioux Falls woman asked, I had a hospitalist take care of me when I was in the hospital. Medicines were changed. It took me a while to readjust to the new medicines, and I can't catch the end of this. My computer's not working.
Yeah, but you know what that comes down to? That comes down to what Jen was talking about, and that is the hospitalist talking to his or her primary care provider in an effective way so that it's seamless. And readmissions, interestingly enough, readmissions to the hospital, which the third-party insurers and Medicare, Medicaid pay a lot of attention to because it's a red flag for problems in the hospital, happens if we don't communicate well. That's where the problem comes up.
We
keep talking about communicating. What's the theme here?
It should always be that, and I would have thought that the computer would have helped us, and it hasn't. It just made it worse. It made it less communication because a computer is too much. It's too many checkboxes.
I think there's computer, but I also think there's a lot of regulation around care now. So, we talked about quality and delivery of quality care. I think that's been a great improvement to healthcare, but I also think there's a fine line. And one of the fine lines is that, for example, we have a controversy in sepsis now where the Center for Medicare and Medicaid has adopted a different definition of sepsis than some of these other payers. Now what is a doctor supposed to do? Am I supposed to diagnose sepsis by how the government tells me to do it or how one of our other healthcare payers does it? So I think it's a fine line to say, to talk about all this communication when I think the powers that be have really regulated us to the point where it's very difficult.
They came out with protocols which are also called recipes. They're recipes that come out whenever you have this diagnosis. Here's the protocol by which we should. When they first came out, I said, problem is, every individual is so different. No, it's just a recipe. You can add cinnamon and whipped cream on the top. It's just a kind of a baseline to give you an idea of what is usually done. You don't have to follow it. Now they say, if you don't follow it, then that's not quality. And that's baloney. The other part of it is almost every protocol is, you got me on it, I'm sorry. Every protocol adds another pill. And the third part of it is, if you look at the protocols and look at the Mayo proceedings, 3 years ago they came out with it, they found that 11% of the protocols are defined on level A data, and 89% are mediocre or poor data. So my comment is, come on, who is this that's controlling this? The physicians have lost control on this, and it's been some bureaucrat that is running
I'm going to push back here for a minute.
Yeah.
Because I basically agree with what you're saying in terms of, protocols are, define medicine. But if we know, and you're right about that. In fact, there was an article in the last year that looked at all of the science that led to what became the recommendations for the latest 2016 Surviving Sepsis Campaign recommendations.
Yeah.
And of those recommendations, it's 67 pages long, the 2016 guidelines.
There's
and you're
like
right.
5 things, probably.
About 10% actually were really quality data. But if you have level, a grade 1, really good solid data, like this antibiotic issue, getting people antibiotics soon and appropriate and delivered, and you're in a hospital, your wife ends up in the hospital where they don't pay attention to that science. And so she lingers in the emergency room, and 6 hours later, she's now got a blood pressure of 70/30 because we didn't pay attention to evidence-based guidelines, different than protocols. then there's a problem there.
I agree.
And when you say, why didn't you get her the antibiotics? Well, in my practice,
Yes.
right?
So
And
I
now you're
agree
on the
with you.
slippery slope.
There is level A data. Let's base what we do on good evidence, and the rest of it, why
So-
are we're being required
So
to
for the
follow.
good of everyone out there, level A data would be if you had a heart attack, everybody gets an aspirin. We know that aspirin
Yeah.
saves lives.
That's-
Yeah,
So-
and why is it level A? Because the science was done rigorously and the studies were
Repeated,
powered
and they're
correctly
power.
and the denominator was large enough and all that sort of thing.
I have to say,
So-
though, that part of where this comes from, too, is back in the probably late 90s, there was a paper that came out that looked at mortality. Death, right? So how often does somebody die, and then how much did their care cost? So if we were looking at the cost of care in California, for example, versus here in South Dakota, we might find that the mortality rates were exactly the same, but the cost was twice as much somewhere else. And people started asking questions, and when we started asking questions, they were saying, you know, only about 40% of the time was that person with the heart attack getting
That
the
aspirin.
aspirin, right? So the goal really was to say 100% of the time we want to get that aspirin, right? Somebody said one time if we had a 0.1% error rate in medicine, like 99.99%, that is the equivalent of 32,000 checks deposited in the incorrect bank account in an hour.
Well, I mean, we could go on and on about
Yes.
protocols, but I have to say that we have 11 questions and we have 2 minutes.
Uh-oh.
So quick answers, one person.
Go.
Okay.
My husband was diagnosed with occipital neuralgia. What is the best treatment for pain? We've tried many things. Good answer?
That is a hard
That's
question
a
to
tough-
that's a-
Miserable
That's a
question.
really tough
and
one.
you know what? My answer is there are some drugs that help, but you have to try non-drugs too.
Yep.
Yeah, I really agree with
A
that.
woman from Sioux Falls wants to congratulate and thank the doctors for explaining the process my husband faced at the end of his life.
Oh, that's
A woman from Flanders, that's nice. A woman from, thank you.
And that's some of the best that we get to do.
Yeah.
That's why what we do as hospitalists and intensivists is so rewarding. Talk about burnout. That's the other side of burnout. To really help someone navigate all that is such a privilege. It really is.
It's a privilege. A woman from Flanders asks, how do you decompress after a stressful shift?
You have to go home and take a deep breath and, you know, be around the important people in your life and remember what's the most important thing.
Absolutely.
Go for a run. What is involved in working at the VA? Okay, that's a good question, but we're going to go on. Kimberly.
Except to say that you get to work with really wonderful people, and the veterans who have served this country who come to the VA are some of the most interesting people that you get to talk to, particularly World War II vets.
Kimberly on Facebook says, do hospitalists ever take care of pregnant patients, yes or no?
Yes, we do.
David asks, what's your opinion on closed versus open ICU?
Okay, open means any physician can take care of you in the ICU. Closed means only intensivists. Well, the reality is that we hospitalists and intensivists, and I think closed makes sense if you define it as hospitalists and intensivists, because we are there all the time. I want someone taking care of my wife who knows what they're doing.
Okay.
So.
Del Rapids asks, do hospitalists help with the discharge planning, especially for the elderly who may need transition to a different
That's a great
environment?
Oh, yeah, that's a lot of our job, actually, is doing discharge planning. It's the most difficult thing that we do.
Man from Sturgis, everything in the medical record is in computers, not books now. If we're come to the ICU, how do doctors know which blood type or other important facts about me? You can find it in the record.
Yeah, the other thing is you can say to the person's family member who's their advocate, what's their blood type?
What's their blood type?
Can you bring in the medical record?
How does palliative care differ from hospice?
Palliative care is more about goal setting and planning of care. So if I got a terminal illness of some kind and I said to you, Dr. Holm, my goal is to go drink fruity beverages on a beach, I would like to tailor my medical care to being able to do that activity, then we could do that. Whereas hospice really is about
End of life.
end of life.
All right.
Good answer.
And now for the winner of tonight's Prairie Doc quiz question. Find the best answer. What is the biggest challenge for hospital systems regarding hospitalists? Burnout, payment, keeping focus on practice mission, keeping them hired. The article I read was retention, keeping them hired. Do you agree?
It's tough to keep quality people. I think burnout's an issue. It really is an issue.
So, well, we
Yeah.
said retention. It was Bill Jesse who answered the question correctly. Thank you, Bill, for participating. A book will be in the mail to you soon. We'll be right back after this.
Have you heard? The Prairie Doc has a radio show. Listen to your local South Dakota radio station for Prairie Doc Conversations. This program features physicians and other health professionals discussing various medical topics important to you and your family. Ask your local radio station if they broadcast Prairie Doc Conversations.
Thank you for listening. Until next time, stay healthy out there, people. For the last 2 years, as I've been wrestling with my own health problems, I have experienced superb care provided by emergency room docs, hospital docs, and after I was sent home, outpatient care providers. This included my primary care internist in Brookings, my teleconferencing oncologist from Sioux Falls, and my surgeon from Rochester. I've experienced and benefited from the perspectives of several scopes of practice. There has been a great deal of change from the way we used to do it, and I think we have to embrace the change. When moving to South Dakota in 1981, I was not surprised to learn that those of us in the Brookings Clinic shared call and the responsibility of the ER, took care of our own patients in the hospital, and saw people in our outpatient clinic Monday through Friday. This was a lot of work, but it taught us all to know and appreciate the constant changing face of medicine and gave physicians an up-close and personal relationship with our patients. Then, over time, hospitals throughout the state started hiring docs who worked exclusively in the ER. In Brookings, that change made our home lives better, but we lost some of our ER talents in exchange. Next, maybe 15 years ago, we obtained the E-Intensive Care Unit, or EICU, which gives our ICU patients the advantage of the extra eyes of a remote ICU specialist and allows sicker patients to stay in rural hospitals. However, the biggest change in the last few years involves how those patients admitted to hospitals are now being cared for by a hospital care specialist or hospitalist. Presently, when patients go home, there is a handoff that must occur between the care of the hospitalist and the patient's own primary care provider in the outpatient clinic. It is this handoff which many believe could be better and is the center of an ongoing debate among doctors. I would advise patient and family to watchdog this transition to make sure the hospitalist spoke with the outpatient care provider. Scientific evidence-based studies have shown that the best overall care happens when care starts with an established outpatient primary care relationship. The best and least expensive health care would happen in this country if everyone had a designated primary care provider who would hand off and receive from the hospital team when necessary. Change is happening, and the benefits far outweigh the risks if only each of us could find and establish a relationship with a primary care provider. Well, a big thank you to our guests, Jennifer and Michael, for volunteering to join us tonight. Thank you both very much.
Thanks for asking.
Last flu season, South Dakota experienced over 870 hospitalizations and 60 deaths. It really isn't too early to get your flu shot. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
No one wants to be a burden, but sometimes all of us need help. And just who do we turn to then? Caregivers caring for us at home. Next time, On Call with the Prairie Doc.